Neurotheology, context to neurointervention and neurorehabilitation. These three musketeers of neurosciences, I mean, these are all very different things. So, welcome, let's dive into these. Probably it will help to appreciate your neurons and nirvana. Well, neurointervention is emergency. You imagine in a way that it is emergency plumber 24/7 available to you. Okay, so that's neurointervention. Neurorehabilitation is your personal gym trainer who keeps you fit, or for me, who keeps my neurons in shape. And neurotheology is something which is your philosophical guide to drive your neurons to divine and attain peace, happiness and joy. So everything is in brain, as I always say. I'll be skipping slides. I couldn't prepare slide for this particular talk. Well, brain, I have been discussing old brain, new brain in my previous talks also. Primarily when we were talking of neurorehab, we have two types of problems. Either it is a progressive problem in neurology like degenerative disorder, Parkinson, Alzheimer. So you have to address them differently. And there is something like an insult coming like out of bolt, stroke or head injury, which are regressive. You treat them better, you have better neuronal plasticity happening there. Well, so again, not going into the depth of that, neurointervention. I am your emergency plumber, 24/7. So many things we do. I mean, I have been trying to use my own experience, like for spontaneous intracerebral hemorrhage. All of us would do medical management. All the years we have been hearing this. But I tell you, if it is more than 60 ml of blood in your brain because of hypertension, which is the commonest cause of brain hemorrhage, 3-month outcome is very dismal. And if it is more than 100 ml, nobody survives. So what do you do for such patients? You don't operate them. There is no surgery, as of now approved. So this is something started from my cath lab. We started doing catheter-based respiration. It's a simple catheter which was built in our lab, and we tried to aspirate this. Obviously, this was under a research project. And this really helped. It really helped. I will not go into details of this, but this is under DST project trial. So you have to do this within first 24 hours because secondary brain injuries, edema, toxic liberation from hemoglobin, from RBC breakdown, and all these things will happen a day later. So you intervene before that. So that's one thing. I'll be sharing certain new things which we thought I'll be sharing with you. So this is what it is. As I said, 60 ml more than, GCS less than 8, mortality is 90%. So you have to do something other than what we have been doing for years for all these patients. So this is how it looks like. You aspirate, hematoma gradually reduces. This is the previous scan, and this is 14 days later. Okay. This is a very typical picture, something white in CSF spaces, subarachnoid hemorrhage. First severe headache in life, especially after a late night party, could be an aneurysmal rupture. So this is subarachnoid hemorrhage. One of my colleagues today only lost a patient from this in Delhi. So this is something you have now, this anti-coiling, as me and my colleague, they have now this, without opening your brain, you can do this coiling. Earlier, surgeons used to put a clip. Nowadays, you have better options. I mean, not better. Surgery is still gold standard, I would say, but these are minimal invasive options. You can put some platinum into the brain and occlude these aneurysms. This is again another patient with aneurysmal coiling. Nowadays you have even more devices. This is a broad neck aneurysm. So you have something called flow diverter. You can just put a flow diverter across the neck of the aneurysm and it thromboses. Quickly, so the most common thing we do, these are intervention for subarachnoid hemorrhages I showed you. Most common thing we do now day in, day out is, if there is large vessel occlusion in the brain arteries and patient is within first 24 hours with us, this is simple animated pictorial depiction that how you take this thrombus out. It's technically just a 5 to 10 minutes job only. But as I said, most important thing is patient has to be within first 24 hours preferably. As Anand was mentioning, it is no more 3.5 hours. Earlier was for IV thrombolysis. Now IV thrombolysis has been extended to 4 hours. And mechanical thrombectomy, which is shown here in this video. You put a catheter across, something like, most of us are aware of urinary catheters. This is catheter in the brain. And you put a catheter here, put a stent retrieval device. Unlike in heart, where you do primary angioplasty, here you have a stent retrieval device with which you just entangle the thrombus and take it out. So this is a stent retrieval device inside. And then you open the stent, let it be for a couple of minutes, and take everything out. So if it is a soft clot, especially best results appear when there is a cardioembolic stroke. So, because I think I will skip this. So this is how a basilar artery occlusion with a high morbidity and mortality of 80%, you recanalize within first 24 hours, you achieve and salvage your brainstem and all this posterior circulation. This is a young male with left-sided weakness. You all can make it out. Tight carotid stenosis with middle cerebral artery occluded, tandem lesion, poor prognosis, young male. So you just open these arteries. So this is probably the best cath lab as of now in the state and around. So this is a biplane cath lab where we work. So you just open this. So this is what I was saying. We do emergency plumbing day in, day out. And you have established MC circulation here and it carotid angioplasty. But here comes the catch. This is the old case. So basically, this was a young boy. When I did this intervention, I was very happy that I did a great job. Patient was conscious. But I went to round the very next day. There was a Bangladeshi colleague of mine who has come here for something. So the guy was uttering something like that. Ami Kushardo. I did not understand Bengali. So the Bangladeshi guy was telling me, he is saying I'm hungry. I thought it is neologism. His jargon. Maybe I created some thrombus here and there. I created some small complication. So for me, he was saying, I was astonished. A guy from Barber would speak in Bengali with no exposure. So this was a surprise. I thought I created a complication and God saved me. So I just quickly, I told him, no, it's not like that. And, and with medical management, it became all right in the next few days. But this was a thing which I was not able to understand at that time till I read this article that certain things, surgery, intervention, trauma to brain, they are in coma and they sometimes start speaking a different language. Still you can't explain this completely on scientific basis. Okay. Well, so here comes spiritualism, neurotheology, that's science of spiritualism. So basically, all of us, WHO says, health, what is health? Complete physical, mental, social well-being, not merely absence of disease. We all read in our PSM books. Well, WHO itself has added fourth domain to health, that's spiritual health. So it is already, endorsed by WHO, spiritual health. So spiritual health of a doctor, spiritual health of the patient, both are important. So how does it make, because this neurotheology has actually contributed and given me some treatment solutions also. Why I'm saying it is relevant in our day-to-day practice also, I'll tell you how. So basically, see, what I was trying to tell you, but in Western literature, in Oxford textbook, Oxford dictionary, spiritualism means a belief that died person can send some signal and there are specially empowered people who understand them and deliver to a normal person. So that is the definition of spiritualism. But if you look at it in Indian context, आध्यात्म, जो अध्ययन से आत्म परिचय कराए वही आध्यात्म है. तो हमारा कॉन्टेक्स्ट ही अलग है स्पिरिचुअलिज्म का. सो बेसिकली आध्यात्म एक ऐसा विज्ञान है जो जीवन में प्रेम, शांति, खुशी और विवेक की शक्ति प्रदान करता है. वो हमारे मानसिक जीवन और आंतरिक जीवन को समृद्ध करने के साथ साथ हमारे आपसी संबंधों को बेहतर करता है. सो दिस इज आवर डेफिनेशन ऑफ स्पिरिचुअलिज्म. Then comes rehabilitation. So I'm just putting three things together. I'll try to make some sense out of it. In Latin, habitual that means to make able again. Because 50% of stroke or even other head, brain insults, they have some residual impairments. And many times these are not picked up. whether it is in cognition, motor impairment, speech impairment, or occupational problems. A surgeon who was fantastic, his motor power has returned, cognition is nearly normal, but he is not able to generate that kind of surgical result after a head injury or stroke. Occupational deficit. Well, so we have newer technology and tools. The whole idea of doing this Neurorehab, today we were discussing the traditional neurorehabilitation, manual therapies and all these things. For cognition also we have pencil and paper test and many other things, but there are many new things. The new things includes virtual reality based therapies, robotic therapies, brain-computer interface, you have heard of this. Then for me, obviously all these things are software-based therapies of particular disease, a particular software. So this is going to be the future in population like ours, where treatment is expensive. So software-based therapy for a mass would be more applicable. I'll show you how. But here for me, the newer tools for me is music and yoga. So these are also important tools, and that's what, this is not I have read in books, this is our own experience also, and we have done trials and research for that. Well, now you imagine this figure, Indian stroke figure. We have 18 lakh strokes, 6 lakh has large vessel occlusion. In our state of Rajasthan, we have almost 1.25 lakh stroke per year. Out of this, 40,000 have large vessel occlusion. Large vessel occlusion means cerebral artery is occluded, or anterior cerebral or basilar artery is occluded. It's large vessel occlusion, and they have poor prognosis. And could you imagine how many thrombectomy, the procedure I was showing you in the beginning, that removal of thrombus from middle cerebral artery. So thrombectomy is done in how many patients per year in our state? 100 patients per year. So that's the pity. Even in India, it is like 2,000 or 3,000 patients now. Even latest figures are like this. So you can understand the huge gap here. And half of the thrombectomy are done in my institute, because still there are availability, but probably it is awareness, infrastructure, or whatever, financial reasons, whatever the reasons are. But this is a very bad thing, which needs to change. Well, stroke, this is a very interesting figure. As you rightly said, I am your 24/7 plumber. Doctors themselves are, at high risk, and especially emergency physician. Physician average age is 80 years. For emergency physician, average age is 58 to 60 years. That's known thing. Then, second thing is 300 to 400 physician every year. This is not Indian data. Obviously, we don't have data in our country, but 300 to 400 physicians commit suicide every year. That's what I'm saying, spiritualism. What is the importance of spiritualism? Not only in the life of the patient, but for the life of the doctors also. So almost a medical college size of doctors is lost every year in the US. So that's, and I really don't know what the figures are going to be in India if we have. Surely more alarming than what it shows here. Well, as I was saying, there are impairments. Motor impairment after stroke in almost 70% patients. Cognitive impairment almost in 20 to 30%. That includes anxiety and depression also. Well, now you see this Binet 1. Now you see this case, a 19-year-old college-going boy is the son of a shopkeeper living in a village. The guy had a stroke, acute onset, right-sided weakness, zero power. He reaches to district hospital where CT facility sometimes is there, sometimes is not there. And he goes to nearby CT center on the same day, and most of the time report is not delivered. The very next day he goes and the report is given as infarct or whatever. And 24 hours gone and he is referred to a tertiary care center for treatment. So, result, he is given aspirin, he is taught physiotherapy and goes back home. The guy is handicapped, crippled, lifelong, shopkeeper father, he takes care of the person, whole family is doing. This is real life story when I see day in day out in my practice. So this is the pity of having a stroke. You die of heart attacks, but stroke really kills your family. So, this was the problem. I realized. So what we did is initially, we just did a plasma DNA thing, cell-free plasma DNA, biomarker. There is no biomarker for stroke established like DROP-T or CT can be for cardiac problems. So we thought that we have machines, PCR machine everywhere now, in our zone also after COVID is more so prevalent. A cell-free plasma DNA, I'm just Not going in details, we already published it. Again, this is under DST project. We have got patent for this. This 300 rupee test, which gives you prognosis for a stroke. Somebody has 5,000 or 10,000. He has to be immediately rushed to a, even if it is CT based, he has to be rushed to a nearby center for emergency treatment. So this does help in treatment optimization also. The reason of doing this test was, मेरे पास जो पेशेंट्स आते हैं बिकॉज थ्रोम्बेक्टमी कॉस्ट अराउंड 2.5 to 3 लाख रुपीस. तो पेशेंट बोलते हैं ओके हम करा तो लेंगे डॉक्टर, बट क्या गारंटी हमारा पेशेंट ठीक हो जाएगा इससे. मेनी पीपल कैन नॉट अफोर्ड 3 लाख रुपीस. So this gives you fear. So I changed two things in my practice because of this question, because our patients are not insured. So European and American trials really does not give right kind of solution to us. So we have to really look for our setting. So we devised this plasma DNA and we started doing an MRI based protocol. All over the world CT based protocol is there, but we do MRI based protocol. Reason? It's a 12-minute protocol designed in our institute. So anyway, so this protocol works with us very well because MRI immediately, it's a 12-hour MRI protocol, it immediately gives extent of remark. The brain is gone, which CT will not pick up. Then why do you do recanalization? It could be futile recanalization. So our outcome was significantly better when we did MRI based protocol because every minute matters. CT you can do in few minutes and you are damaging cells, but you have to really look into, and this scenario is most of the places in India. It is not here in Udaipur specifically, everywhere in India. So you really have to think in terms of financial things also. So these two things did help me a lot. This is a tight carotid stenosis. So this is after opening this. This carotid stenting, because in medicine you learn things and you unlearn things. It was 2006 when I joined NIMHANS as assistant professor. I was junior most faculty, very enthusiastic, did my neurointervention training, joined there, and the very first seminar I got is published in NEJM, New England Journal of Medicine, carotid artery stenting, case closed. So for me, practically, it was a very disappointing thing, but now you see time has changed. Stenting, nobody talks of carotid surgery nowadays because we do kind number of stenting in a month is not done by surgery. All over the country is not done that number. So you cannot compare apple with oranges. So this was past, this is present, and I always believe the future is going to belong to pills and vaccines for whether it is coronary stenting or carotid stenting. Traditional imaging, I always talk against luminal stenosis. 80% blockage है, खोलना है, 30% नहीं खोलना है. ये हम coronary literature में सुनते हैं. Medical carotid में भी ऐसे ही बोलते हैं कि 50%, more than 50% symptomatic stenosis, you have to open it. But again, this concept is not valid. I tell you why. Because sometimes, carotid bulb is a large area, degree of stenosis. If suppose plaque grows outside, then you will not have stenosis. The area itself is large, so there will not be significant stenosis. Then you do not know it is vulnerable plaque or not. It is a plaque to be ruptured. Now I come to the real point here. Vulnerable plaque. Plaque which has propensity to rupture. Whether it is coronary artery or brain artery, anywhere. You have a plaque, whether plaque is vulnerable to rupture or not, you simply pick it up by MRI. If it is ulceration is there, if it is large liquid core is there is intraplaque hemorrhage. So these are the plaque who are going to rupture despite of minimal degree of stenosis, let's say 30%, 40%. A 90% stable plaque will not produce event. And you can, many times people say ना कि हमने bypass ही नहीं कराया, हमारा तो इतने सालों से काम चल रहा है, हमने ये कर लिया, वो technique कर लिया. Because you have stable plaque in 3 of your coronary arteries, you can live for another 10 years, that's fine. So this, so as to prove this, so I always tell my stroke colleagues that a blister aneurysm, a 1 millimeter aneurysm, you put flow diverter and you treat it very vigorously. Oh, it might rupture, it might bleed. So what you do, blister aneurysm is small aneurysm, 1 millimeter. You can't operate it, you can't put coils into this. So new device came up, flow diverter. So if there is an intraplaque hemorrhage, why don't you treat it? So these carotid arteries are normal looking, but they will fool you. The patient has intraplaque hemorrhage, so there is a vulnerability to rupture, intraplaque hemorrhage, no significant stenosis. Then I did, but this is something I felt over the years, how to prove or disprove this. I did a trial, and that was published in leading stroke journal in the stroke. I did a trial comparing 30 to 50% stenosis, and so this we did MR based plaque imaging, and this gave us answer that all the plaque which were vulnerable, so you can pick up on MRI. So you compare, you have a case here, bilateral carotid stenosis, you have a case, you have a control, you can compare them. So this showed us very well that MRI plaque imaging gives you as good result as histopathology and alert you that this plaque has vulnerability to rupture and produce the event. Well, vaccination, I always say it's not a myth. Once we have it, it will help in many of the atherosclerotic disease. There are better drugs. Well, this is an interesting case. There is no significant stenosis here. There is some kind of pseudoaneurysm here, carotid stenosis. It's post-radiation, C.A. Darren's case. I think, sir, it was your case probably. It's a very old case, old one. So C.A. So we had put 2 stents here. Post-radiation stenosis, you don't do angioplasty. There are fibrotic things. You are not able to open it. So you have to just put a stent, try to recanalize them, and this is 4 weeks after, vessel is almost recanalized. So here comes another interesting part, neurotheology. I mean, neurotheology, one of the things, Ashtanga Yoga is there in our ancient literature. So you have Yama, Niyama, Asana, Pranayama, Pratyahara, Dharana, Dhyan and Samadhi, that's absolute bliss. So Yama and Niyama tells you about many food habits. And one of them is, which is very favorite to me, is turmeric, curcumin. The active ingredient is curcumin. And unfortunately, when I talk to my pharmacology head, I want to do a trial on curcumin. I mean, everybody said haldi works everywhere. Sumac dressing which you apply for wound also, and that's haldi only, that's turmeric. So, but he said, allopathy mein ye curcumin hai, you don't consider it as a drug also. So there is हमारे pharmacology textbook में भी we never thought about curcumin. It is not a drug. It is a super drug. This was curcumin for 4 weeks, followed by this kind of healing. So anyways, we did not get any permission for conducting a trial on curcumin because you cannot do drug trial today. So then what we did after so much perseverance, we considered it as a nutraceutical, not a pharmaceutical, and we did some work. So we are already undertaking this project maybe in next, because every trial would have 1 year at least. In next year maybe I will be able to share you more data. So what we are looking at, those who are given turmeric, those who are not given, we are looking at stroke outcome by MRS score, power change, cognition change, or whether the plaque from unstable turns to stable. So these are the end points we will take with this. So the whole idea is such a use curcumin, you combine this. The problem is when you drink this curcumin or turmeric milk, most of the time we have own milk at home and it gets out. It is not water soluble. So this is fat soluble. So take milk with fat content, mix 1.5 to 2 teaspoons. I mean, you will say it garmi karti hai. So this is the actual dose of the curcumin. It is 500 milligram of curcumin, or you can have tablets of that, which unfortunately today we do not have. And you add a dash of piperine. Piperine is from black pepper, kali mirch. So that increases bioavailability by 2000 times. So combination of curcumin with piperine is next thing. A pharmaceutical combination which is of great help because it is a potent anti-inflammatory. So this will, wherever there is inflammation, it's not outside your wound inflammation that will be suppressed because it's a strong COX-2 inhibitor, lipoxygenase inhibitor. It is antioxidant and many properties. It is blood thinner also. It builds up, it prevents build-up of cholesterol plaque. It controls your sugar. It is used, lot of uses in oncology also. I wanted. So basically, wound healing, sumac dressing you all see and do it. And so this curcumin is such a powerful. Why I am saying for the sake of repetition also. So this was one thing. Well, then Yama and Niyama. When I was doing this thrombectomy plumbing in the brain, when I was taking this thrombus out, and I subjected them to metagenomic analysis. Metagenomic analysis is a new generation sequencing to pick up any kind of infection. Like we do culture. Culture doesn't pick up actually bacterial DNA. It gives you 2% DNA. But this NGS will pick up even if there is a single bacterial DNA in a given sample, wherever. I mean, you do thrombus or sputum. So, most interesting, and this we published, metagenomic analysis of thrombus sample retrieved by mechanical thrombectomy. So, there is a whole list of 27 bacteria we got in first few patients itself. And these all bacteria were not pathogenic. You will say, why the bacteria is there in the brain? It's a sterile compartment. So these were patients which is artery to artery emboli. So these bacteria were non-pathogenic or low-grade pathogenic, which are already commensal to us in our oral cavity, skin, gut, lactobacillus, Pseudomonas fluorescens, Staphylococcus hominis. I'm not talking of aureus. I'm not talking of Pseudomonas aeruginosa here. So how do they make a plaque vulnerable for rupture? So here comes the mechanism. In addition to, and there are indirect mechanisms also. So this is the chart which we published. What are the mechanisms for that? But imagine these are in and around our body only. So you have smoking, hypertension, hypercholesterolemia, sedentary lifestyle, genetics, all these risk factors for coronary artery disease or stroke. So you have here a new factor which I termed that as a vidra. And vidra is nothing but I again took it from yama and niyama, hygiene. So good hygiene, and that is why I was surprised when I was talking in API meet in R&T. So Professor K.C. Jain was telling that in our medicine board they used to keep a brush at the time of late Shurji Singh ji. So that time probably mechanism was not there, but he knew that dental hygiene is so important that it can lead to heart attack and strokes. So this again, yes, you have to combine. This is cognitive rehabilitation, a slide I took from one of the faculty today in the presentation today. Basically here you have different disease specific and impair specific softwares now. Probably we need to have Indian software in coming times. I will skip some of these slides. So neurorehabilitation, because what I am saying is neurorehabilitation is acute our intervention is acute. Neurorehabilitation is a prolonged intervention which requires more patience, probably more art than science. So again here, because neurorehabilitation is not merely moving limbs, as sir also discussed that it has to be intensive, it has to be repetitive. You have to devote 5 to 6 hours every day for your cognition, for your motor problems, for your occupational problems. So then it gives a better outcome. Combine newer with older tools. So you have to have qualified neurorehab specialists. The concept today is whosoever is near to your home or cheaper, you will call at home and do physiotherapy. That's what we do. But that could work in orthopedic patient, but not in neuro patients. That's the message. So in brain, you use it or lose it, use and improve it. Specificity matters, repetition matters, intensity matters, time matters, age matters. Well, so this I will skip. This is regarding speech rehabilitation. I will skip this slide. Virtual reality is a very simple tool. Now this is available at our center also. It's kind of virtual reality means simulation. Digital simulation of an environment. I don't know swimming, but I am diving and I am swimming inside an ocean. So that kind of feel you can have when you have immersive kind of virtual rehabilitation. Then you have semi-immersive, which we do in our lab. That person who has zero power, he is chopping vegetables. So this is virtual reality, but he learns to use his hand, and that gives him a kind of confidence and motivation to do it further. So this is again, so I would simulate it to the, in Glasgow coma scale we have 3 to 15. In a spiritual sense, if you ask me the highest stage is absolute unitary being, that's AUB. That means you are lost in the God. So kind of in virtual reality, practically you are lost in virtual world. So this is in our center, all these. So these all things now you have in Udaipur also. So neurorehabilitation, because these are the things. I will not again skip these slides. And in COVID time we did our own e-rehab program which worked out very well. So it's not, in COVID we learned that it's not always necessary to touch a patient. You can do online things and many times you succeed in that also. And this is our own paper in yoga and music intervention to reduce depression, stress, anxiety. That was during COVID time. So this worked very well. For headache also there are many other things. So this is our own trial where we compared almost 800 patients over last 4 years in our department, and the worst thing is there was hardly 20% retention. We tried everything. We tried to make it free and everything. But you can imagine, patient followed up for 20% followed up till 1 year. The recommended Neurorehab, 80% did not. So you can imagine the scene outside a tertiary care institute, what the patient would be doing. So this is how it was. And here the study was regarding conventional and neurotechnology tools. So MS, stroke scale, MRS, MMT, all these were better in those who had added neurotechnology tools. We did not replace conventional tools. So, spiritual need of the patient is important. A caregiver should understand that, and that is why many times religion and spiritualism are not different for most of the person, though it is different, but it is not different. Because most of the time we are taught in our religious practices about spiritualism without knowing it. So actually when I started my practice, and I found most number of patients in Auri Mata temple. 16 years back I started there, I treated their priest and everyone, so now again I went there 1 year back. And so you have to go to them sometimes. So there are various tools for doctors also to meet their spiritual needs, spending time in nature, like you are today with your friends, hobbies, talking, discussing. So this is again spiritual. For me, spiritualism is some tool by any practices, be it yoga or meditation, or you are more happy from inside. You are good at yourself. Once you are good at yourself, you are good to your family also. You neglect smaller problems, and then you are better at workplace also. So your workplace doesn't remain anymore a daily core of earning money, but it becomes a place of joy for you. Well, for clinicians, because now I am coming to probably last part of my talk. Intelligent quotient you all know. You all have high intelligent quotients. Doctors are their highest intelligent quotient people. Emotional quotient, some of them may be good, some may not be good. Like Dr. Anand is very good in his EQ. He will always remember his friends and do stuff. Very high IQ person. I know him, so I can tell it. But spiritual quotient is something which one has to develop, and this is the highest form of intelligence. Okay. Well, before I come to that, for doctors in our routine practice, hope is a very simple tool. Hope means we can ask our patient, what are your hope, strength and peace? Do you follow any religion? Because most of the time, people who follow religion, they go to temple daily, they avoid greed, they avoid stealing, so they are better people. Not all, but many of them. So somebody who follows religion has a better chances of being a better spiritual person. Okay. Then personally, do you practice some spirituality, meditation, yoga, worship, and what are the effects on your life? So you ask 4 questions, and actually this gives you a great connect to your patient, and you understand him better, and you can treat his disease better. Especially a person like me who stays with patient for 10 days. Madam would deliver a patient and next day wo ghar chala jayega. So that does not matter. But once there is a prolonged problem for me and for Dr. Manoj, where we treat chronic patients also. So it is, you have to know their spiritual needs, and you know your spiritual strength and weakness also. And that is why many problems would happen. So this is how you calculate spiritual quotient. So I will not go again detail of this spiritual quotient. So I come here. So this is, who was the first yoga guru, whether it was Lord Shiva or Patanjali? I lead this debate. So basically, I have already told about this Ashtanga yoga, which gives us this 8 component. Now I come to again a correlate of spiritualism and brain. We all know about this lobe, we know about these functions, sensation here, executive function here, memory, understanding here, occipital lobe is here. We have almost more than 6,000 thoughts every day in our brain process. Brain works on electrochemical signals. Brain and tissue, as I always say, but you all know what is the difference between brain and tissue. Well, there is something called, I have written here spirituality. This is your parietal brain, more so your posterior superior parietal brain, and there you have a frontal lobe. I'll just come up because this is again through what, as a neuroscientist, what I can do. I can read brain. easy for me, very easy. I just put EEG electrodes. And like in heart you have very simple waves, but in brain you have waves in frontal, parietal, temporal, you know it. Then you can do functional MRI, again you can have a real-time picture. And then you have something called neuropsychological testing. You can test each and every specific function. There are detailed neuropsychological testing. So that's the whole idea of having, complete department, psychologist, speech therapist. So here what we did was, when we were looking at these, conscious subconscious mind. This is again a very important thing, faith and emotion. So most of you would say, if I ask you what is more important in life, faith or emotion? Emotion or logic? So you say logic is more important. For me, I'm a doctor, logic makes more sense. But it is not the case. Suppose somebody has a fear of flying. He knows that his aircraft is not going to have an accident. Most of the time it doesn't happen. But somebody who has a fear of flying, he will not board aircraft because emotion wins over logic. Somebody who is fearful of darkness, he will not go in darkness despite knowing that he is not going to pose any danger of threat to him. Well, so here I come, IQ, SQ and EQ. Higher dimension of intelligence that activates quality and capabilities of soul in the form of wisdom, compassion, joy, love, energy, creativity and peace. So it improves your personal life, as I told earlier also, improves your family life, improves your work life. Well, I'll skip most of these slides. Because I'll just skip all this, I'll tell you crux of this in the end. So we did this project actually. As I said, science and spiritualism. Spiritual experiences, those who had it, one thing I can say, they are intense, very clear. They have a sense of unity, they have a sense of surrender, and then it becomes permanent in your life. And again, skip this. Every religion has, some or other form of this. Yoga was published in Times. Why? Because there were a lot of smokers in US at that point of time. Somebody told this would help in quitting smoking. So sometimes popular things are, so this, I'll come to this AUB. So see, I'll tell you crux of this because rest of the slide I'll skip. What we did is we did EEG, we did neuropsychological testing, we did, because functional MRI we did not have, but you can do functional MRI also. What happens when you ascend in your yoga or meditation, once you are very regular, so let's say as early after 4 weeks, your frontal lobe lights up. So once your frontal lobe lights up, you have more alpha wave in your frontal lobe. So by EEG you know that. Okay, alpha is, parietal lobe goes down. So you have more theta and delta waves in parietal lobe. So these two phenomena you pick up on EEG and neuropsychological testing. Okay, so what will happen? We all know that function of your concentration will improve if frontal lobe lights up, executive function will improve, but at the same time, you are sitting there, I am here, so there is a dichotomy between two of us. So self and world, so orientation to time, place, person is a function of parietal lobe, you all know that. So parietal lobe goes down, you lose that dichotomy, self-world dichotomy is lost, and the highest stage, according to me, this is again, once you lose this dichotomy, probably you feel one with the world, and that's AUB. And at the same time, what happens, once this phenomena will happen, you have immense spurt to your hippocampi. So your hippocampus, your amygdala, it fires and gives you sense of pleasure, joy, and sometimes something which we never felt with yogic people would feel, that awe. So, same thing, I'll not go because this is EEG detection of the same problem. So there various techniques I have told, because I was working with Brahma Kumaris, so I have many patients with Parkinson's disease with them. So one of them went to Dr. Vinay Goyal, so did some functional MRI. Somehow the dopamine receptor uptake level increases after doing continuous yoga practice. So they handle Parkinson better than normal population. They have less requirement of syndopa and all other doses. Like in our patient, it progresses, they are able to handle it for decades altogether. Maybe Kirtan Kriya was one thing where you have, Alzheimer patients and all those. Again, I will not go into details of this. So Yoga and music, I was telling in the daytime also, he has a lecture on music therapy. Music is something very simple thing, melodic intonation therapy. Somebody who is a Broca's aphasia, if you, he will not be able to make phrases, but he can sing. So use this ability to, improve him. But a patient with global aphasia will not have benefit with that. Well, so this was our own result. So again, this is already published paper. This was our module of yoga and meditation. How we subjected this patient for 1 hour every day. So this is our module, and this was in our department. So I always believe, and I believe in this, that we actually underuse in our brain, because I always say that suppose I give you 10% of your salary every month, would you be able to live happily? But if you are using 10% of your brain in your day-to-day life, how miserable it is, though we don't realize it. So the only way to increase your brain capacity from 10% to let's say 60-70% is through some practice. It is definitely not through our textbooks only. So you have to increase your spiritual quotient. So you can prevent many diseases to happen, number one, and you can handle them better, number two. And once it is happening, I think overall outcome is also better. That needs another study probably. So this is how I believe that this works. Thank you very much.
तो हमें पता ही नहीं था कि पिछले 20 साल से मैं चुप साहब डॉक्टर प्रशांत अग्रवाल स्पिरिचुअल हीलिंग कर रहे हैं. जब हम सब दोस्तों को कलीग्स को हर महीने यहाँ साथ में बुलाते हैं, एंड वी बिलीव डॉक्टर वाजपेयी टेलिंग ट्रूथ अबाउट friends coming together and it's a treatment of stroke through neurotheology. We are doing it every month, sir. So let's hear for ourselves that we have been doing it for more than 20 years. Indian Medical Association has been doing this. So that was on the lighter note, but listening to Dr. Abdullah, I think it needs a complete day just encompassing these three topics together about the neurorehab, neurointervention and neurotheology. And with the pin drop silence in the whole lecture hall, with such kind of erudite audiences, I'll say, not on the speakers, because speakers तो बहुत अच्छे हैं ही हैं. All these doctors who have been stalwart in their own fields have been listening to you so thoroughly, so patiently about the things and outcome what they have been doing it for years together. Because most of them has crossed that age of emergency physician. If you tell 58 to 60 होता है, उनसे सब ज़्यादा यहाँ पे है. So you have successfully crossed that 58-60 level, then you are here. So you have managed it well, sir. And just to continue on that, we have 3 more erudite speakers with us. Can somebody assist me in getting the chairs here? So instead of having a single deliberation and a monologue about the discussion, what we can do for ourselves and for our patients, we have converted that into a panel discussion. And these are the 4 speakers who are here with us. Can we have them on the stage? Dr. Atullah, can we first come up and start introducing the speakers? Dr. Nirmal Surya, Dr. Praveen Surana, and Dr. Arvind Nanda, sir.